Over to our presenters, Lisa Walsh from Advocacy team and Laura Dowling, Senior Advocate. Lorraine's going to introduce them formally in a moment, but I just want to say the objectives of today's webinar are really to provide an overview of patient advocacy service and the national advocacy services and looking at how they can support the open disclosure process. We're going to demonstrate how advocacy service can support a person with reduced capacity, show how advocacy service can assist patient service users in the process of open disclosure, and also using a person-centred approach for any service provision for patients or service users with a disability. And really, we want to share the person's lived experience, which is really what it's all about at the end of the day. All the work that we do is based on the patient, service user, and their family. So I'm going to hand you over now to Lorraine, who's going to introduce our speakers. So thank you very much and do enjoy the webinar.
Thanks, Angela, and I'm delighted to welcome Lisa and Laura to the webinar for presenting today. It's a very important topic, and certainly it's a fantastic opportunity to link in with the Open Disclosure team. Very much similar sentiments, I suppose, on our journey in speaking for the patient and the principles behind it. So Lisa Walsh is our advocacy team lead with the Patient Advocacy Service. She's worked in that role since 2019 when the service was first launched. Previously, Lisa was working as a senior advocate with the National Advocacy Service for People with Disabilities since 2015. And before that, she was working in the disability sector. And Lisa is also another additional exciting role. She is also the chair of the board in a newly established children's mental health service. Laura Dowling, senior advocate within the National Advocacy Service for People with Disabilities. And she's worked in that role or in that area since 2013. So again, very experienced. Laura has a background in psychology and humanitarian aid and has worked in health and social care for the last 13 years. And she does have a particular interest in education and also teaches and lectures at Trinity College in disability studies. And Laura's current role has a particular responsibility in raising social policy issues for persons with disabilities in accessing services and supports. So we're very grateful that you're presenting for us today, and I'll hand over to you.
Thank you. I think you've just unmuted me there.
Thanks, Lisa.
So good morning, everybody. Thank you very much for that introduction, Lorraine, and that welcome as well, Angela. And I suppose thank you so much to the Open Disclosure Office for having us again. We really appreciate the opportunity. You have such a wide network of people who attend these presentations and who are happy to listen to, I suppose, what we do, how we do it, and how we can help people within the hospitals, within nursing homes, I suppose, for PAS in particular, and to be able to share that message. So today I'm going to take you a little bit through the Patient Advocacy Service in particular, and then Laura will focus on the National Advocacy Service. So the Patient Advocacy Service is provided by the National Advocacy Service for People with Disabilities. It's commissioned by the National Patient Safety Office and we're funded by the Department of Health. And I suppose this is really important for us because it means we are independent of the HSE, which is very important for the people that we support as well. The origins of PAS then. So in 2014, there was a Primetime Investigates programme that aired on the deaths of newborn babies at Portlaoise Hospital. I'm sure something everybody was familiar with. And I suppose part of that looked at the subsequent treatment of families after that happened. Following this, then HICWA did a report on Portlaoise and released that, and then the Ombudsman also did a report called Learning to Get Better, an investigation by the Ombudsman into how public hospitals handle complaints. Within both of those reports, they recommended an establishment of a patient safety advocacy service. And within the Ombudsman's report in particular, the National Advocacy Service was cited as a really good example of a very valuable advocacy service. Following that, then there was a commitment from the programme for a partnership government to develop a national patient safety office. This was then established, and then a tender was released in 2018, which NAS provided feedback in. NAS then successively won the tender then in late 2018, and the service then began a scoping engagement piece in 2019. We looked at where we were to focus, where do people need us most. We wanted to provide a very high quality advocacy service, so I suppose we want to do a gradual expansion of our service. So initially we began in the acute hospital sectors back in 2019 in October when our service was launched. And since then, in June last year, we've extended our remit further into HSE operated nursing homes as well. And in 2020, obviously with COVID, has impacted every single one of us. And it did kind of slow some of the growth for us as a service. We were hoping to be out into the community much earlier. But we've moved very quickly with the times. We've moved online, doing presentations like this, and I suppose we've tried to move in ways that we can. And we work from home, and I suppose these gradual presentations and being able to extend our remit has supported us to be able to move out into the community. So we're now in both acute hospitals and HSE operated nursing homes. So the vision of PAS is to support a person with the right to make a complaint. So a person has the right to have guidance and information when an issue arises about their care and treatment, which may lead on to them wanting to make a complaint or want to seek answers through the aftermath of a patient safety incident. And some of our core values are listed there. It's dignity, autonomy, equality, and independence. Human rights is the foundation of how we work, and that person-centeredness that Angela mentioned about how we operate, and that's very important to us. So as a service then, our remit is to provide a free, independent and confidential support and empowerment advocacy to people who use public acute hospitals and to those in the HSE operated nursing homes wanting to make a formal complaint under the HSE or servicer say process. Or in the aftermath of a patient safety incident, if somebody is looking for support within that as also. So the model of advocacy we provide is an empowerment advocacy, and this is slightly different than the National Advocacy Service. We don't generally do representative advocacy, but we can offer representative advocacy at times when needed, in particular for nursing homes. And again, just to mention, we don't receive HSE funding, which is something that's important to the person looking to use our service. So just to give you an idea of how we operate as an organisation with managing our staff. So we are a national service, and as I said, we have extended our remit since June 2021 into HSE operated nursing homes. All of our staff are fully professional, trained advocates. There's a very competitive open recruitment process, and you need to either have relevant experience or a degree in a relevant discipline. All of our staff are also, after completing the certificate in the patient safety and complaints advocacy, which is provided by the Open Training College. And we're also part now, we're further down the line of actually delivering training within that course in relation to advocacy as well. I suppose we feel that we are kind of leaders in the advocacy field, and that's reflected in us being involved in delivering that course. We have a suite of code of practice and policies that all of our staff have to adhere to and follow, and it's something that as a team lead we monitor and make sure that everybody's working within that. And something really important that happened for us last year was an agreement between the HSE with a Memorandum of Understanding. So within that MOU, we looked, and I suppose what we have is an agreement and a framework around cooperation and communication between ourselves and the Patient Advocacy Service and the HSE. Now this is particular for public acute hospitals, not for nursing homes. I suppose we will be looking down the future for something similar, but as it stands now, this is just for public acute hospitals. So this Memorandum of Understanding, part of the agreement was to make sure that it looks to enable and enhance how we deliver each of our own organisations. So I suppose we've made a commitment that we would look to promote the awareness of each other's services and our respective roles. So I suppose for us, this means that the patient advocacy service will be promoted by the HSE to people using the service through the complaints and incident management processes, through their staff training, through their local services. And the hospitals, I suppose, will facilitate the patient advocacy service to help raise awareness about our organisation within the hospital settings. So that may look like posters, which we're happy to supply, or leaflets, or doing something like this and come into your hospital and speak in, doing promotional stands, variety of ways that we can do that. Another part of it is around cooperation and engagement. So I suppose we're looking for the HSE and relevant hospitals and hospital groups where appropriate and where the person using the service requests that the patient advocacy service, for example, might be corresponded in a response to a complaint. They may request that we're CC'd in it, that's supported and facilitated. That if the person is being invited to a meeting again and they're looking to have their advocate present with them, that's something is facilitated and engaged with as well, and that we're involved in all of those bits and pieces. So that's all within the HSE MOU, which is fantastic to have and to work together. So to give you an idea of the advocate themselves and I suppose what they do on a day-to-day basis. So for us, when we get a contact in, we call it an inquiry. So there's a number of different ways people can make an inquiry to our service. So we have a national line number, and I have that a slide at the end, and I'll give you that number. They can send an email, they can send a letter to us. We have a website which has an online portal that you can submit a form to us if you're looking for support. We have a large social media presence as well, and again I have links for all of those. Or in person, so for example, hopefully when all is good and we can get back into hospitals and we can have a face at the door, or we can have maybe a stand or something if people want to approach us. So inquiries can be made in a number of different ways. So they can either come from the person themselves, or maybe a relevant person, or sometimes we have other professionals who will ring us and kind of ask, I have somebody here, I want to know, are you the service, are you not, how can we help and how can we support? So we're happy to take those calls as well and give direction. So if somebody is making an inquiry on behalf of another person, a one-to-one advocate and a case will only be opened if we have the consent of the individual themselves. And where this may change is if the person is not in a position to give consent. So for example, if somebody is in a coma and they're unable to give consent at that time, but as soon as they're able to, we'll seek that consent. In that case, the person must be a relevant person seeking support. Any person who makes an inquiry to the patient advocacy service, even if they didn't have consent, we will, in any way we can, try and provide them with a level of support. So even if it's not for us and it's not within our remit, we will always make our very best efforts to give that information and help to the person. So this may look like a couple of different ways, I suppose, is how we may do this. So information provision and advice. We may signpost them to a different service that may be more appropriate, so maybe over to our other service, the National Advocacy Service, or simply it may be redirecting them back to the PALs within the hospital if it's something that they haven't done already, and seeking that initial support first. Sometimes we provide long arm support where maybe people are just coming back to us every now and again when they want support at the next stage, but they don't want an ongoing piece. And then we do, eventually, it's the one-to-one full-blown advocacy support that we provide, where we start at the beginning and we work through until there's a resolution or until there's no other options for the person. So if the person is eligible and wants that one-to-one advocacy support, an advocate or an advocacy officer will work with them on their specific complaint within that your service, your say process, or under the IMF in the aftermath of a patient safety incident, and I suppose in line with open disclosure as well. And as I said, we will work on this until either the person is satisfied with the response or we can't progress it any further. Some of the ways then that they can help, and I suppose this helps both people in hospitals dealing with the complaints as much as the person. So some of the things they might do is accessing information and identifying and understanding, I suppose, the options and the possible outcomes that are available for the person, assisting them in preparing their documentation and correspondence during the formal complaints process. So I suppose some of the things that we have found very beneficial, and we've had very positive feedback from a number of hospitals, is that that 12-page letter that gives you every single piece of detail has been condensed into something that's succinct and understandable. And it's very clear that this is the person's complaint issues and this is the person's outcomes that they are looking for when they're making their complaint. And that's been very supportive, I think, for both sides. We also look at providing the person information and support and allow them, I suppose, to speak up for themselves. I suppose we're looking to empower them so they can represent themselves. And we provide support after the complaint is made. So I suppose that's looking at the response, looking at their options, so they can decide, I suppose, how they want to proceed. Are they satisfied, or do they want to look at other options? Within that, then we give information and support in relation to the aftermath of a patient safety incident, open disclosure, what that should look like, how it should happen, the process, the language that's used, the different personnel, and then under the IMF, the review process and those different bits and pieces as well. We may attend meetings, I suppose, currently for acutes in particular. I suppose we're a support person, we're generally not an active participant. Within the nursing home settings, we do have a bit of an option to do representative as and when needed. And that's particularly for, I suppose, the individuals where you're looking who may have dementia and may need more representative advocacy. We will help them in advance of the meeting. We do a lot of work to prepare them to get the questions that they have, kind of, again, succinct and in a way that they can ask, let them gather their thoughts, and I suppose look for be clear on what they're looking for. Look at referring them on to another service then again. So maybe, you know, somebody's very traumatized or something very serious has happened, and looking at who can support them within that. And then we also support them going on further to other regulatory bodies, for example, the Ombudsman or the Medical Council or Nursing and Midwifery Board. And as I said, it is empowerment advocacy that we do strive for, and only as and when needed may we do representative advocacy. So the nature of our work, I suppose, is to not take sides. So our advocates and advocacy officers want to make sure that the process is balanced, it's fair, that the person's individual concerns, their views, their decisions, I suppose that all of that is heard and addressed. We're independent and external to the hospitals and the nursing homes. And I suppose that's why we do mention about not receiving HSE funding. And for a person, whether there's a perceived or there is a conflict, this is something that's really important. We look to work with the hospitals and the nursing homes to improve the complaints process and to highlight any social policy issues or systemic issues we may identify. And I suppose we're looking to highlight them then onto stakeholders. And part of the MOU, I suppose our hope is that within the acute hospitals, that this will create a pathway that we can identify key people within the hospitals that we can link in with directly, I suppose, and try and make that process as easy for everybody. So for your service, you're saying in particular, stage one, we will just be providing information and support, and we will be redirecting people back to the hospitals. We will be asking them to go back to the PAL if there's a PAL within the hospital, or go back to the nurse manager or whoever is relevant that they need to speak to. It's only at stage 2 that we will look to open a one-to-one advocacy case and to make a formal complaint for that person. And then, as I said, we do work through stage 3 and 4 also. So some of the things we won't do, so we don't act on another person's behalf, we don't provide mediation, initiate redress, we don't overturn a complaint. As I said, we will only work to its natural conclusion, whether it's the person being satisfied or there is no further options. We don't provide counselling, legal or medical advice or support. We don't replace the Ombudsman, engage in activism or campaigning, and we don't replace any of the staff that are within hospitals either. I suppose we're looking to work together to enhance the process rather than to take over and replace. So why would you have an independent advocate, or why would you tell somebody that here's the patient advocacy service, they may help? So I suppose some of the reasons are, if a person has requested an independent person, as I mentioned, to avoid that conflict, whether it's real or perceived, or if it's just from the person, it is an independent person and they are entitled to it. People have the right to have an advocate. There is legislation and different pieces of documentation, and even if you see within the open disclosure policy, within the incident management framework policy, all the policies that we work with, there is mention of advocacy supports. So the person has that right to have that should they choose. We find that it's brought a lot of balance to the process for the person who may not be familiar with the language that we use, the terminology, might not be familiar with the processes themselves, can find it very difficult to negotiate and manage, and it's just kind of brought a bit of balance for them. We look to improve the efficiency of the process as well, I suppose, and we're ensuring that the complainant themselves is providing adequate information for you as the person within the hospital, that you can understand what their issue is, what they're looking for, and to be able to, I suppose, give a good response to that complaint rather than trying to figure it out. So it's like that, as I said, taking that 12-page complaint letter down into something that's more succinct for you to follow. Maybe somebody doesn't have any natural supports, so maybe they haven't got family, or they're on their own, or they choose not to have them involved. I suppose that's just as important. So even if somebody does have a family member and doesn't want them to be involved in the process, it may be a good idea to seek the support of an advocate. We're looking to enhance understanding for everybody. So we're trying to make sure that the complainant themselves, that they're understanding what's happening and looking to have the complaint resolved at an early stage. So as I said, we do redirect people back to the hospitals, and it's only at that formal stage where they're looking for support that we give that one-to-one advocacy. We look to have it resolved early, so I suppose we don't want any escalations, both for the person and for the hospitals as well, to avoid any costs or any further stress or trauma that might be felt by the person. And I suppose we're also a useful referral pathway, so we do send people on to other services, and we do have connections, and I suppose we are independent. And one of the other things that we look to do is to identify systemic failures and patterns. I suppose we are in a very good position that we see issues and trends and themes of complaints, and we see it from a national perspective. So it is something that we do feedback on, and I suppose we look to kind of make sure that these things don't happen again. And I know even when the open disclosure team were looking at reviewing their policy, we're able to feedback on that. So that's some of the other work that we look to do. But just to give you a case example to try and, I suppose, make it easier to understand what exactly we do, I'm going to give you an example of a lady called Mary. Her name that isn't the real name, but that's the name we're going to use for this. So Mary had a very traumatic experience in relation to her maternity care in hospital. She felt it was a really difficult situation, and she did not feel that she got the support she needed from the hospital staff. Mary wanted to make a complaint about her care to the HSE, and she requested a copy of all the files the hospital had about her. However, the Freedom of Information request she sent to the hospital was turned down. Mary didn't know why this had happened and didn't fully understand the process, so she contacted the Patient Advocacy Service, and we provided her with some support. She was assigned an advocate, and they listened to her experiences. They gave her opportunities to explain her concerns, what outcomes she wanted, and then they supported her to write a letter to appeal the decision under the Freedom of Information Act to get her files. This was successful, and then Mary received all of her files. And Mary reviewed the files with her advocate, and I suppose in doing that, she found that she was involved in a review process. Her care had been involved in a review process, and she didn't know about this. And she wasn't told. So the open disclosure didn't happen for Mary. Mary said she was very angry about this, and she felt like she wasn't getting a chance to have her own say on her own experiences for something that had happened to her. So Mary's advocate helped her to request a copy of all internal reviews relating to her case, any minutes or any other bits and pieces that were in relation to that. So when Mary got her records, her advocate again spent more time with her going through that information, so she fully understood what had happened, and then supported her to look to the option of making a complaint if that's what she wanted to do. And I suppose Mary felt that this process was very traumatic. She felt very upset and very stressed because the open disclosure hadn't happened at the early stage in the way she found out. Mary's advocate then explored her options with her and explained what they were. For example, did she want to have a meeting with the hospital, or did she want to make the complaint? So having the advocate there, Mary said it felt like everything was explained to her, and that it gave her confidence to make her own decision about what she wanted to do. Mary said she didn't know how she would have coped if she didn't have the advocate there, and if she had to do it on her own. So Mary decided to take part in the hospital internal review process, and was able to voice her concerns. And then the outcome of that was that the hospital gave her an apology and agreed to improve support going forward to other women in the future. And Mary was really happy with that. So I suppose the outcome of this case shows the importance of having a knowledgeable advocate from the Patient Advocacy Service to ensure that the voice of the person is heard and that the person is included in the process. The support and the information provided to Mary by the advocate gave her confidence to voice her concerns, and she was able to do it in a way that they understood what her questions and outcomes she wanted were. She was able to have a say about her own experience, and she received an apology, which is something that she was really happy about, and she was satisfied with that outcome. And then that was the end of the process for Mary. So just looking at advocacy and open disclosure in particular, as a focus that we had mentioned, we would look at this. So some of the challenges people supported by the Patient Advocacy Service have had in relation to open disclosure are open disclosure meetings being inconsistent across the hospital. So for example, maybe the terms used are different, or the names of what the open disclosure meeting are different. And it's not always consistent. So sometimes it can be very hard to establish for us when we're talking to the person as much as the person at what stage of the complaint they're at, or if they've had an open disclosure meeting or not. When the meetings are named different things, this can be very difficult for the person to understand or even realise that open disclosure has happened. There's been challenges around minutes for open disclosure meetings, or like that, there hasn't been an open disclosure meeting at all. And similarly, as I said, names are being changed as to what they are. As in Mary's case, some review process have been taken place without the person being involved or without the person being informed. And I suppose sometimes we've had cases where people have only found out that the review has taken place when a report has been issued. To work together, I suppose, with hospitals, the Patient Advocacy Service would ask, I suppose, that the patient safety incident, if it has occurred, we feel that if we're there at a very early stage when these open disclosure meetings are taking place, that it will really be of benefit to the likes of Mary or other individuals like Mary, that we are offered as a support to the person. And some of the supports we can offer is explaining that incident management framework process, explaining the open disclosure process, explaining the terminology and the jargon that are used. We have found that when we're involved very early in the process, when open disclosure has been made, and before any review or before any terms of reference or designated liaison person or any of those things happen, we found that the person has the option to reach out to us should they choose to or not. We're happy for our leaflets to be shared as well. So if you're writing a letter inviting somebody to an open disclosure meeting, we're very happy for you to send out our leaflets if that's something you're interested in doing. And I suppose if they contact us, we can tell them all about us and what we do, and then it's up to them if they want to use us or not. Some of the feedback we've had from people who use our service again is just who may have been in the middle of a process and then found out about us, is that they have said, they wished they knew about us from the start, that they felt that they really got a good understanding of what was happening when we were able to support them. And I suppose like that, some of the things that we do, as I mentioned, was explain the processes, explain where the person might be in the process. And to do that, sometimes we may support them to seek files, for example. So in relation to maybe incident reports, non-clinical files, any meeting, any review meeting minutes, all those different bits and pieces, open disclosure documentation, and try do that under FOI to try and get a good understanding for the person. Just to give you a quick snapshot, I suppose, of how our service has grown since we are in operation. I suppose 2020 was our first full year in operation, and we had COVID, so that obviously changed things. And then last year, I suppose, we extended our remit. So as you can see from the graphs there on the right hand side, between 2020 and 2021, we had an increase of 25% in new contacts to the service. and then complaint issues that we identify. So we do this under the healthcare complaints analysis tool, which I know some hospitals are using as well. So within that, we've had 157% an increase on complaint issues identified. So that's just a kind of a snapshot as to where we're at. So in 2020, I think we had 535 contacts, and then in 2021, this has increased to 1,205, which is fantastic. We do look specifically at COVID-related complaints, COVID-related type complaints to see. Again, we've had 313 of those, and sometimes they have their own trends and themes as to what type of complaint issues people have. Late last year, we launched 4 reports, an Advocacy Matters series, and I know Kelly has a copy of those links, and she'll share that onto our website, and 4 of those reports are there if you want to have a look at them. And these looked, I suppose, at reporting and highlighting the experiences people supported by the Patient Advocacy Service have experienced during the COVID-19 crisis. As mentioned, we have extended our remit into HSE operated nursing homes, and I suppose within that then our organisation has expanded as well. So we've increased from a staff team of 9 when we started, and we now have 19, and this is going to continue to increase, which is very exciting for us. We've recently undergone an evaluation of the service under CRO, and I suppose this was very positive feedback from the people who use our services, which is very exciting. The number of followers we have on all our social media has increased as well. Going forward, something we would ask for yourselves who are listening to this, I suppose, is to look at working with us and collaborating. So if somebody's looking to seek our support, or you think somebody may benefit our support, for you to share, as I said, our leaflets, we've posters, to have these displayed in your hospitals, to invite us along to speak like this to your teams so they understand what we do. And we're not looking to replace yourselves within hospitals. We're looking to work together and have collaboration going forward. I have a list of our contact details here, and again, I can share the presentation at the end so everybody can have that. As I said, we're on LinkedIn, Facebook and Twitter. And just before I finish, to give the person's experience, I'm going to play a video of 3 individuals who have used. One was the National Advocacy Service, and 2 were the Patient Advocacy Service during COVID. So if you just bear with me when I switch over. Thank you for that. And I suppose that's me done on my end from the Patient Advocacy Service, and I suppose just thank you to everybody for listening.
Thank you very much, Lisa, for a fantastic presentation there, and I think really well rounded up with the patient stories at the end and the case history. So bringing home that message, just how important that advocacy is for us all, really. In my own experience as working as a review officer, some of the work that you do is so important, and particularly identifying what the issues are, because as a review officer, it's very easy when you look at a complaint to decide what you think what the patient needs to resolve the complaint, but very often when you meet with the patient, it's something completely different that they need. So I think very strong messages. Just while Laura's getting set up, there are a few questions there for you, Lisa, if you're happy to take them.
Yeah,
and
sure.
One of the things was, what is the position of patient advocacy services with regards to independent advocates working outside of PAS?
What's the position?
Yes.
So I suppose if we're not the appropriate independent advocacy service, we will always signpost people to another more appropriate advocacy service if there's one that isn't relevant to us. We have a very focused remit within supporting people to make a complaint within the hospital setting and the HSE operated nursing homes. So if there's anything outside of that and there's another advocacy service that provides something that the person needs, we will always signpost them on if that is the more appropriate source. So for example, Ian, the Irish Advocacy Network, who supports people around mental health might be one, for example, or as I mentioned, like the National Advocacy Service, if it is a person with a disability who needs other advocacy. So we do signpost on as and when appropriate.
Perfect. Thanks very much for that, Lisa. There's another question around, is PAS replacing SAGE advocacy and the relationship between NAS, PAS and SAGE, I suppose?
No, SAGE is another advocacy service that's out there. There are several, and I suppose NAS and the Patient Advocacy Service were all part of the National Advocacy Service organisation. We both have different remits, but I suppose we both work from the same values, and like as an organisation, that's that dignity, that autonomy, that independence, that empowerment of the person. And I suppose SAGE is its own organisation. And again, as and when appropriate, if there is something that comes up that isn't for us, we may look at signposting to SAGE or Ian or other advocacy services that are out there.
Okay, and another question, can a next of kin require advocacy for the relative if the relative has dementia or lack of capacity?
So any relevant person, so if somebody is a son, daughter, parent, under the Your Service Your Say policy can be deemed a relevant person. So depending on what that complaint issue is, I suppose we will always look, as a service, we are guided by the person, and we will always look to seek that person's consent. So we may do that piece ourselves to try and get that consent. There is a process that we do, and I'd say Laura's probably going to touch on it a little bit more in her representative style of advocacy in NAS that we do, where we do look to support the person as much as possible, seek their own consent, how we do that. And if not possible, we do look at supporting somebody who is a relevant person within the Your Service Your Say process and the policy to make a complaint.
Thank you for that. I think there was a couple of questions around that actually, Lisa, so a bit of confusion there around the different advocacy services. Another just question, one of the challenges we face during the complaints process is managing the expectations of the complainant. How do you manage expectations as an independent advocate? A bit like I was talking to earlier about.
Yeah, and I think that's probably why the earlier we can get involved, I think this is where we can support managing that expectations piece. I suppose we can be very real with the process, and this is what it is. And I suppose we do look to seek what are the outcomes the person wants. So if they are really unrealistic outcomes, we look to manage their expectations as to, this is what may happen. This is what your options are. From our experience, this is what we have seen as an organisation. So we do try and manage those expectations. And I think for us, there's a huge amount of work that goes in advance of somebody supporting a complaint when we are supporting them. There's a huge amount of work at every stage. So even when there's a response again around managing their expectations, if they are looking for internal reviews or going to regulatory bodies around, again, what are the outcomes you were looking for and to manage that expectations piece. It's something that's very important because we want a positive outcome for the person. And I suppose that's why it's so important to manage everybody's expectations as to what the hospital can and can't do.
Thank you. And just the last question, we'll hand over to Laura then. Will the service of PAS be extended to HSE-funded residential service for people with disabilities?
So I suppose there is a request, and there will be, as part of our organisation, to extend further out into the community. And I suppose what we are doing is gathering data and information to look at where next, where appropriate is next. And I suppose obviously part of that is guided by our funders and the Department of Health as well. So to look at where is the service needed. So part of our remit initially is to extend out into the likes of primary healthcare centres, residential centres, community mental health, all those different areas. And I suppose we're just doing a gradual expansion of service. And as I said, at the minute it stands with the HSE operated nursing homes. But as time progresses, we will be expanding further out into the community again.
Thank you, Lisa. So we'll hand over to Laura now. Lisa, maybe you might come back at the end, though, if there is any further questions at the end of Laura's presentation as well.
No problem, Angela. Thank you.
Million. So I'll hand over to Laura now.
Thank you very much, Angela, and thanks, Lisa. I'm checking everyone can hear me and my slides are working. So my name is Laura Dowling and I'm Senior Advocate with the National Advocacy Service, and I'm based in the team that we're calling the Greater Dublin Region. And as Lisa said, that the National Advocacy Service has a relationship with the Patient Advocacy Service, and we share a vision of a society where for a National Advocacy Service, it's people with disabilities, and that they can exercise their rights with dignity, autonomy, equality and independence at the core. And we're an organisation that acknowledges the capacity of people with disabilities to make their own decisions in accordance with the United Nations Convention on the Rights of People with Disabilities. So because as I can hear that there is some confusion around different advocacy services, and you may have come in contact with the National Advocacy Service over the last number of years, I want to tell you a little bit about where we've come from. So we were established in 2005, and in 2005 we were a series of pilot projects. So we were embedded in different organisations, and there would have been an advocate embedded in an organisation. Since 2014, we have become a national company. So we are the National Advocacy Service, and we have a management team that's over the entire country. And then we would have 4 regional teams who have a manager, an administrator, a team of advocates and 2 senior advocates. We're funded by the Citizens Information Board, and we're supported by the Citizens Information Board. And that's really, really important to us because it means that we can provide independent, free and confidential advocacy. So we don't have a conflict of interest in terms of where we're funded from. We're a fully professional organisation, so every member of staff in the National Advocacy Service is paid, and there are about 50 of us working in the National Advocacy Service at the moment. And the National Advocacy Service staff, we all work across the country to the same suite of policies and procedures. So a person in Cork is getting the same service that the person in Dublin and the person in Mayo are getting. The National Advocacy Service, I suppose I think sometimes it's important to see the context of the different services that are out there, because there can be some confusion. So the Citizens Information Board are also provide MABS, which is the Money Advice and Budgeting Service. Then we've got our Patient Advocacy Service that Lisa has just told you about. There's the Sign Language Interpreting Service, and then there's the Citizens Information Offices that provide information. And there are suites of sister services to the National Advocacy Service. And this is our setup. So we've got 4 regional teams. We've got the Greater Dublin Region, which is Dublin and Wicklow. Then we've got the Midlands and North East. We've got the Western Region, and we've got our Southern Region. And as I said, each team is under our national management structure, and they would have their own team with their own manager and their own team of advocates. Okay, so the National Advocacy Service, this is who we work with. We work with adults exclusively, so people over 18. And we work to support people with disabilities. However, we have a particular remit for working with certain groups of people. So this is our access and eligibility. This is who qualifies for a National Advocacy Service advocate. So we look to work with people who live in the community and are isolated from their communities. and their services. We're also looking to work with people who communicate differently. We work with people who are inappropriately accommodated. So that could be a young person living in a nursing home. It could be an adult living at home with parents. It could be a person who's living in a congregated setting, or it could be a person who's living in a community setting but has an inappropriate people living with them and is very unhappy where they are. And that could be a person that's inappropriately accommodated. We look to work with people who live in residential services, people who attend day services, or people who have limited informal or natural supports. And I saw some questions coming in earlier in the chat about referrals to advocacy services, and anybody can make a referral to the National Advocacy Service. We call a referral an inquiry. And anybody can call our national line, which is up on the screen there, and that's operating from 10 a.m. till 4 p.m. weekdays. And then we also have an inquiry process that's available on our website. And we get inquiries from absolutely anybody. So it could be the person themselves, but also service providers, service funders and commissioners, health and social care professionals, legal professionals, different advocacy groups, can send an inquiry into the National Advocacy Service. However, we are a service that will only work with people who want to work with us. So when an inquiry comes in, we will look to meet or speak to that person. And when we're looking to speak to that person, we want to hear what it is that the issue is that they want advocacy support with, and the context. So what sort of supports have they got available to them? What sort of natural supports have they? What sort of professional supports have they? And we gather that information, and an advocate will assess whether that person is eligible for the National Advocacy Service. So whether they meet our access and eligibility criteria, whether we're the right organisation to support that person. If we are, the person will have a case opened with the National Advocacy Service, or potentially go on our waiting list if we have capacity issues at the time, or they'll be signposted elsewhere to a different organisation that's more appropriate to support them. So at the very core of the advocacy work that the National Advocacy Service does is the presumption that a person has capacity to make their own decisions, unless or until the contrary is shown. So advocates work from a presumption that a person can make their own decisions, and advocates will go to great lengths to support a person's capacity. So an advocate might look at supporting a person to access information in a different way to the way it is being presented, maybe to pull back on the timeframes that a decision has to be made, or the amount of people involved in the decision, whatever it is that that person needs to support them to make their own decisions. That's what an advocate is there to support with. And advocates provide advocacy on a will and preference basis. So sometimes will and preference is best understood when you contrast it with best interests. We're all familiar with what is in our best interests, and will and preference is what we want to do. Sometimes those things are aligned, sometimes they're not. And it's a very ordinary experience. It's an everyday experience that we will make decisions that are our will and preference, what we want to do, but that are not aligned with what is our best interest. When people are in receipt of services, that can become a little bit more complex. And sometimes people are encouraged to make decisions that are in their best interests, but are not necessarily what their will and preference is. So advocates provide advocacy on a will and preference basis. We do what that person wants to do. And we do this by getting to know them and getting to know the supports that they want and what it is that they want. So sometimes a person will come to us with a very clear idea of what they want. Other times people need support to explore their available options so that they can figure out what it is that they want. And advocates support people to be directly involved in decision making. So advocates work to make sure that the person has a seat at the table and that they're the ones that are communicating their will and preference. And we are always working that towards somebody doing what it is that they want to do, including taking considered risks and experiencing failure. And I mentioned earlier about our funding being from the Citizens Information Board. Advocates are not influenced by any other party. So we absolutely work with all of the other people involved in the situation, but other people will have opinions on what that person should do, and so other people will have responsibilities and different outlooks depending on whether they're a professional person or a family member. But an advocate's role is to stay with the person that they're supporting and to support their will and preference in the situation. So advocates work by ensuring that fair processes have been followed. So if somebody has experienced a rights violation or has a complaint, they will look to explore all of the available options that are out there for a person to seek recourse, and then support a person to choose how they want to address the situation. So advocates work with people, as I said earlier, who have communication differences. And not communicating verbally or not communicating in a way that's easily understood is definitely not a barrier to having an advocate. Advocates use 4 internationally recognized approaches to working with people who are difficult to understand, and they're on the screen there. So when an advocate works with somebody who can't communicate in a way that's easily understood, they'll use these approaches, and usually a combination of all 4. So there's person-centeredness, where a person might go and look at all of the plans and the things that are going on in that person's life. Then there is a rights-based approach, where an advocate will look at how a person's rights are impacted by the situation that they're in. Then we'll use ordinary life principles. And the ordinary life principles are 8 quality of life domains that guide what it looks like, what a good life looks like. And an advocate will examine whether the situation at hand, how it impacts on a person's quality of life. And then the last one that we use, and we use often, is witness observer. And it's a very low tech way, but we will sit in a person's environment at different times, and we'll observe what's going on in their day and their interactions. And it can be an incredibly powerful experience to see how somebody's day maps out and the different things that are happening to them and the different impacts their environment is having on them. So the National Advocacy Service completed or provided representative advocacy to about 1,000 people in 2019, which is just over a 10% increase on the year previous, and would have closed 431 cases. We also would have completed nearly 3,500 short one-off interventions, which might be writing a letter for somebody, making a phone call, or referring them on to a more appropriate service. And we would work on an incredibly broad range of issues. So when somebody comes to us with an inquiry, the issue that they want advocacy support with could be from an incredibly broad range of things. We would work on healthcare issues. We would work on abuse, neglect, mistreatment and exploitation. We would work on issues that are around risk, and whether somebody's been prevented from taking a risk and having their rights infringed on as a result. We would work on access to justice issues, legal issues, people in all types of courts, work with people who are inappropriately placed. We would work with people who have financial issues, who might want access to their money or having difficulties with banks. We would work on quality of life issues and rights restrictions. We're about 50% of our casework can be to do with housing and accommodation. This can be to do with access to residential services. It can be to do with inappropriate services. About 23% of our work is to do with health. So that could be mental health, physical health, can be within hospital settings. Then about 12% of our work is justice issues, which can be where somebody is a victim of a crime or might be accused of a crime. Also, someone who could have family law proceedings, and an advocate can support them to understand the court process and to participate in it. And 8% of our work is to do with parenting with a disability. And that usually is a parent with an intellectual disability who is involved with the Child and Family Agency, with TUSLA. And advocates work with a person to attend meetings with TUSLA, to interact with the social work system, and then also to interact with their legal team if it's a court situation, and to attend court. So advocates in the National Advocacy Service work with people with all types of disabilities. Around half of the people that we work with would have an intellectual disability, but we would also work with people with all types of disabilities, and you can see the percentages of those disabilities on your screen there. And then advocates also, as Lisa mentioned earlier, the National Advocacy Service, just like the Patient Advocacy Service, is in a great position to get an overarching national view of trends and themes that are coming up again and again in a social policy environment. And so we would contribute that knowledge and that information on a national level. And these are some of the different groups and projects that we've led or participated in recently. And then the last thing I wanted to mention in terms of how advocates can work. So the McCoy report, What Matters Most, 2 advocates contributed to that, and they would have worked and done an exercise called A Day in the Life, and they would have done a witness observer piece with some of the residents who were living in Ursa Tracta, and they would have written an account of a day spent living the life that that person had been living. So now I wanted to conclude with a couple of case studies so that I can better explain the kind of work that the National Advocacy Service does. So I wanted to start by talking to you about Lottie. So Lottie was a woman who had an acquired brain injury, and she had spent a prolonged period of time in hospital, and had come to the opinion when she came out of hospital that she had acquired an additional brain injury in hospital. And she had been through the hospital complaints procedure, and she had been to PALS within the hospital, and she was very frustrated because what she wanted out of that process did not happen. And when she referred to the National Advocacy Service, she was very frustrated and was at the point of emailing absolutely anybody in the hospital to try and get heard. And the advocate worked with her to plan what it was exactly that she wanted from that process. And the advocate was able to help her pin down what it was that she was trying to find out and what information that she needed. And then the advocate and Lottie went back to the PAL service. And this time they had a completely different experience because Lottie was clear about what it was that she was trying to get from her interaction. So Lottie spent some time working with PALS, and she got all of the information that she needed. And then she took that away. And then the advocate was also able to support Lottie to link that information to her own day-to-day supports, her social care supports, her clinical supports, her psychology supports, so that she could go back to that information, and she could be supported to go back to that information. Another person that I wanted to tell you about was Carly. So Carly, she had spent the majority of her adult life living in an on-campus congregated setting, and she had disclosed to the staff team that something had happened to her during a residential stay in a hospital when she was a very young adult. And she and the staff there supported her to do all of the appropriate actions that they needed to do. And during the course of doing all of that, Carly decided that she wanted to see her file from that time in the hospital. And they wrote to the hospital and they asked for the file, and they were turned down. And when they referred to the National Advocacy Service, the advocate made contact with the hospital, and the hospital informed the advocate in a way that they wouldn't inform the service that they had decided that they were going to not give Lottie her file, or to Carly her file, because they were concerned about the fact that Carly had an intellectual disability, and they were worried about the impact that the information in the file would have on her, because it was very distressing. And the advocate was able to work with the social care team in the residential service and the hospital to explain that Carly had the right to that information, but also to explain how Carly was going to be supported with that information. And Carly got access to her file. So I'm looking at the time, so I'm going to leave my case studies there. But the National Advocacy Service, the website is up on your screen, as is our national line. And I'm just going to finish with a short video about some of the work that advocates do.
Okay, so thank you very much, Laura, for the lovely presentation, again for the lovely patient stories. I think probably reached all of our hearts this morning, both your stories and Lisa's stories. And really, I think providing a very strong message about the really important services you provide in relation, particularly in our role around open disclosure and preparing the patient for the open disclosure meeting in relation to their rights, in relation to what their needs are, what their expectations are. And when you go into an open disclosure meeting, when the service knows what the patient's rights and expectations are, and the patient and service user knows, it's much more likely to be a more effective and more successful open disclosure meeting. I'm just wondering, just in relation to the advocates, how do they cope when, you know, the will and preference of the service user is not maybe in their best interest, or they see it as risky? It must be a difficult situation for the advocate to deal with.
It's a very ordinary situation for an advocate to deal with. It's our bread and butter in our day-to-day, and the National Advocacy Service believes in people's right to take considered risks and to experience failure. So I suppose it's so ordinary to us to be supporting that really the difficulty is often to convince the people around that person that this is their right and this is what they're choosing to do, and that it's okay.
And I think the Assist Decision Making Capacity Act is really sending that message through as well, very strongly, isn't it, Laura?
Absolutely, yeah. That is going to be interesting for us all.
And would NAS ever refer anybody to PAS, just out of interest?
To the Patient Advocacy Service, of course, yes. And sometimes we would work together. So there would be times when somebody would have a case open with the National Advocacy Service on one part of the things that are going on for them, and then they might also have a case with the Patient Advocacy Service too.
Okay, and just a question from the audience, really. Can I ask where we'd signpost people when the complaint relates to National Ambulance Service? That might be maybe for Louise or Lisa there.
Yeah, and I suppose this is probably a really good example of the support we try to provide always to people who come to our service. So like that, we would give them information on how to do it. Now, obviously, we can't open a one-to-one case, but we would provide the person information and we'll direct them. And again, like we've template letters around how to make a complaint, so we would often share those with the person so they've something to start with at least, and we direct them through it. And maybe just Angela, before you move on, I just was looking through the questions, and I think some of the confusion around the advocacy services is probably in relation to PAS moving into the nursing homes. And I think there was some questions around, I suppose, what does SAGE do versus what do we do? And I just might touch on that if you don't mind. Sorry, I know we're probably over time. So I suppose for the Patient Advocacy Service, our specific remit within the nursing homes is to support a person to make a complaint through the Your Service, Your Say complaints process. And again, if something safeguarding was to come up again, that would be something that we would support and address as well. So our remit is quite focused within the nursing homes, so it is just in relation to making a complaint. And I suppose very often there's lots of other issues that people experience within nursing homes, and like that would be something for another advocacy service. So whether it's the National Advocacy Service, sometimes we do a lot of work where maybe somebody who's under 65 and is inappropriate placed. That's a lot of the work that the National Advocacy Service does. Or if it's an older person who doesn't fit within that remit, then it may be something for SAGE. But so for us, for PAS, it's just the Your Service, Your Say complaints process that we work on, and in the aftermath of any patient safety instance. So it's the same as the acutes, just hopefully that clarifies it a little bit for people.
Thanks very much, Lisa. I think there was a bit of confusion there around the different services. And just maybe following on from that with yourself, Lisa, is there any plans for Patient Advocacy Service to move from complaints to a full advocacy service at all?
No, I suppose our remit is quite specific around supporting people through that complaints process. Like a lot of what the National Advocacy Service does can support us in the other bits and pieces. So they do support in all those different areas that Laura listed in. And I suppose for us, where our experience and our excellence is that complaints process. So if the National Advocacy Service needs support, we do, as Laura mentioned, co-work and work together to share that knowledge and experience across services. So you're receiving that, maybe not directly from us.
Okay, and just a question as well about where people can access professional training on advocacy in Ireland. What courses are available out there that you're aware of and could direct us to?
All the questions, or if you've any, like I suppose one is the certificate in patient safety complaints advocacy. So that one is run in the Open Training College. So that course has recently just started in January, but they do run specific patient safety complaints advocacy as one.
Mm-hmm.
I don't know if you have any others, Laura.
There aren't many specific. I think there's a couple of courses that do master's degrees that include advocacy, but I don't think there's a huge amount of outside of the one that Lisa has just mentioned.
I think we've just somebody in the chat's put in a course about empowerment and advocacy, Open Training College as well. So that might be another course for people to go to. There's another couple of questions there. Do you ever work with speech and language therapists involved with clients who would know their clients' communication strengths and weaknesses very well?
Absolutely. One of the things that advocates would often do is seek to involve a speech and language therapist in a situation where somebody doesn't communicate in a way that's easily understood. Advocates would often work with speech and language therapists to support communication within a context, and that could be an entire advocacy case to get that support that a person needs.
Great. And will this decision support service impact on either of your services in any way at all?
There will be a relationship between the National Advocacy Service and the Decision Support Service, and there's an awful lot of ongoing communications between the two to talk about that relationship. The Decision Support Service also have a code of practice about interacting with independent advocates. That's it's actually out for public consultation at the moment if anyone was interested in having a look.
Okay.
It's also something that the Patient Advocacy Service is involved in with the National Advocacy Service to feedback in that consultation process. And I suppose we are focusing on that advocacy piece around how do we work together.
Great, thank you, Lisa. And Lisa, just in relation to your leaflet, is it downloadable?
No, I had sent Kelly a PDF, but if that's not accessible, I'm happy for Kelly to put people in contact with me, and we can share our leaflets, or we can post them, whichever you prefer, on our posters. So whatever you need, or again, if you want us to come do a presentation too.
And
So
Lisa,
just contact,
and
directly,
Lisa, if you want, I can send it out. I'll be sending the presentation out to everybody after, so I can include the PDF version of the leaflet in that email as well.
Okay. So I don't know if Lorraine is still there or not. She might want to say a few words. She might have had to go, actually. Just in relation to patient advocacy service, another question there. It's the last question we'll take is who currently funds patient advocacy service? I know you're going out to tender again.
Yeah, so we're funded by the Department of Health. And I suppose that came from the National Patient Safety Office, I suppose, so we're funded directly by the Department of Health.
Okay, that's perfect. So I think we'll just wrap up for today now anyway. And just to say, I don't know, Kelly, you've got the presentation there just to put up in relation to some of our e-learning programs. Perfect. So just to thank both of our speakers sincerely for your, really excellent presentations today. And I think the case scenarios and the little videos just added so much to the presentation today as well. And I certainly picked up a lot of new information, having this been the second webinar that I've been on. So thank you very much. And we really do appreciate the work you do with us. And we will be continuing this excellent working relationship we have with you going forward. Just in relation to everybody who's joined us, just to point you towards our e-learning module, open disclosure training is mandatory training for all HSC staff and staff working in HSC funded services. And e-learning module 1, communicate and effect through open disclosure, is on HSC land. And that will really suffice for most staff. But for staff who are engaging in formal open disclosure meetings, they should also complete e-learning module 2. I think this is a good module for everybody to complete, actually, because it really looks at the process, and we've got really nice videos in there as well. So about how to manage an open disclosure meeting, preparing for it, doing the meeting, and then the follow-up from it. And we've got a piece in around the role of the patient, or the designated person, who's that person who's the contact between the service and the patient and their family. And just I would advise you to go there. Also, there are open disclosure leads in every area. And if you go onto the Open Disclosure website, hsc.ie/open disclosure, you can see who the lead is for your area. And there are leads in a lot of the Federation of Voluntary Bodies as well. So do contact your lead. And there is a revised face-to-face programme that we're working on at the moment, which is being piloted and we're implementing at the moment, which is very focused on the skills required to engage in open disclosure and looking at case scenarios specific to the area that the training is happening in. So we have more webinars planned, and our next webinar is on it's delivered by the National Communication Programme, and it's going to be on February 9th and looking at difficult conversations. And I'm sure those of you who have joined Eva Doherty's webinars on communication, we've had absolutely wonderful feedback from those presentations. They're on our website if you want to have a look at those webinars. But this is a follow-on from Eva's presentation as well, because open disclosure is all about communication at the very highest level, really.
Sorry,
so
Angela,
if you've any,
that should say March 9th. That's a typo.
Oh, sorry, March 9th. Okay.
Sorry
Yeah, that's
about
fine. That's fine, Catherine, no problem. So March the 9th at 11 a.m. And those of you who are on our circulation list, we'll send it to you anyway, and it goes out through Twitter. If anybody has joined today who aren't on our circulation list, just drop a message to our office and we can add you to our circulation. So thank you again to everybody. We will be sending out a post-webinar evaluation as well. So these evaluations are really important for us because even with Lisa and Laura today, we're able to go through the feedback from the last webinar and add in the things that you felt would have helped made it better really for you, and hence a lot more of the case histories and stories there today. So do please complete the webinar, the evaluation. It'll only take you about a minute to do that. And just if you have any ideas for future webinars, do let us know. As I say, we do listen to you. We do want to deliver a programme that you find helpful and useful. So thank you all, and have a good day. Stay safe, and we'll see you very soon. Bye.